Hello and welcome, everyone. My name is Sarah Sims, and I'm the manager of continuing education for the Brown School here at Washington University in St. Louis. Thank you so much for joining us for today's Open Classroom. Open Classroom is the Brown School's virtual and free professional development series. And today we have a very special iteration of that program, our Graduate Policy Scholar Showcase. Before we get started, I just want to do one housekeeping item, and that is that we are in a Zoom webinar format. That just means that we can't see or hear attendees, but we can engage with you through the chat, and we hope that you will share any questions that you have for our scholars today through the chat. We'll have time for a little bit of Q&A at the end. And in the meantime, feel free to use the chat to say hello and where you're zooming in from. So as I mentioned, today's program is our annual Graduate Policy Scholars Showcase. Before we start introducing our scholars and letting them share about their research, I would first like to introduce Gary Parker, who is the Associate Dean for External Affairs at the Brown School, as well as the Director of the Clark Fox Policy Institute. Gary's going to tell everyone just a little bit more about this unique and impactful program that we have here at WashU. Gary?
Thank you so much for that wonderful introduction, Sarah. As Sarah mentioned, my name is Gary Parker. My pronouns are he, him, and I have the great privilege of serving as the director of the Clark Fox Policy Institute. And as part of the mission of the Institute, we provide additional training to students and community members and others. And today is part of our Graduate Policy Scholars Program. This is a year-long program that graduate students from across the Danforth campus here at Washington University can apply for, and if accepted, have the opportunity to engage in what we like to say policy practice. They get exceptional training in the classroom, learning about policy analysis and policy research and policy impact. But this program allows them to find opportunities to engage in seeing, once you have that policy, how do you move that forward? What does the process look like? So they meet with policymakers and legislators. They write policy briefs, op-eds to the op-eds and letters to the editors, and so much more. And today is really one of my special and favorite programs because it is completely student produced. The students who are involved in the Graduate Policy Scholars Program get together and they create a program that highlights some of the work that they've done. So I've had no say whatsoever in this, and I love when that happens. I love when our students take leadership. So with that, I'm going to hand it back to Sarah, and I want to thank all of our students so much. Actually, they've all been inducted, so they're officially Graduate Policy Scholars, and we're so glad to have you as part of a cohort that is just shy of 300 graduate policy scholars. So thank you for being a part of the program. Thank you for inspiring me in all that you do. And I look forward to viewing your work and your program today.
Thanks so much, Gary. So we have 4 of our scholars who are going to present on their research, on their policy research today. I'm going to introduce each of them right before their presentations. And then at the end of the 4th presentation, we'll have time for Q&A. And as I mentioned, you are welcome to drop any questions or comments that you have into the chat throughout the presentations, and then we'll collect those at the end. So first up, we have Baffour-Boaten, Boahen-Boaten. Baffour is a Master of Public Health graduate student here at the Brown School. He has a background in global mental health, HIV/AIDS management, and humanitarian action. He is the chair of the WashU Global Health Student Advisory Committee. And his policy interests sit at the intersection of public mental health, disasters, and humanitarian emergencies and underserved populations. He envisions a career of designing public mental health policies for populations such as refugees and displaced populations in the global south, excuse me. So now I'm going to just turn it over to Baffour to share about his policy research. Baffour, take it away.
All right. Thank you very much, Sarah, for the introduction. So the starting point of my presentation, which focuses on public health and climate change, building system resilience in the context of crisis, and begins with a profound statement made by the Secretary General of the World Meteorological Organization, Peter Tallis, when he stated that climate change is having a growing impact on the African continent, hitting the most vulnerable hardest and contributing to food insecurity, population displacement, and stress on water resources. In recent months, we've seen devastating floods and invasion of desert locusts, and now face the looming specter of drought because of a La Nina event. Now, across the global south, particularly sub-Saharan Africa, they contribute the least to global warming, yet they experience the most severe public health impact. So this is a huge disconnect. And an evidence of that is the realization that the global average of global CO2 production is 4.8 tons. However, sub-Saharan Africa produces less than a ton, which is 0.8 tons of CO2 per person. Now, this is a huge disconnect. You're contributing the least to a problem, yet you are bearing the most of its devastating impact. I think if we could move on to the next slide. Yes, so these are some of the facts to support this very issue. The fact that 4/5 of the Sahel's arable land is degraded due to climate-induced shocks. So if you look at the African map, the area of Mali, Niger, Mauritania, on the west coast of Africa, in the western region of Africa. So all the colored regions of the African continent collectively are called sub-Saharan Africa. So the Sahel region, which is in the area of the countries I mentioned, they are currently experiencing droughts and flooding as temperatures in the Sahel region are increasing 1.5 times faster than the global average. Now, again, in South Africa too, I think last year there was flooding incidents in the KwaZulu-Natal province, leading to the death of more than 400 people and causing a myriad of public health crises. Let's go to the next slide. So these, the preceding slides talk about the problem. Now, why is this important? Because as climate change begins to shape public health discourses across the public health and the global health community, calls have been increasing to build public health system resilience to adapt and mitigate the impact of climate change, because it's increasingly becoming obvious that climate change is something that cannot be stopped. However, we have to adapt and mitigate the impact. So it is imperative that we position our healthcare system, our public health system, to be able to respond and also drive preparedness in sub-Saharan Africa. Now, in that regard, the Organization for Economic Cooperation and Development defined health system resilience as the capacity of a health system to not only anticipate shocks, but also reduce the negative effect of such disruptions, recover as soon as feasible, and adapt by drawing lessons from the experience to become effective and well prepared. So effectively, resilience is about the ability to bounce back after a setback. So especially with what we've seen with COVID, it has become very imperative that health systems build robust mechanisms to be able to contain multiple health shocks that come about due to a number of reasons, not least among them climate change. Next slide. So if we look at why the focus on sub-Saharan Africa is very important, here there are some graphs to show. On the right-hand side, we can see the impact of climate change on health. We can see issues of severe weather can cause injuries and fatalities, and they also confer mental health impact. Air pollution also yield asthma and cardiovascular problems. There is also the change in issues of vector, and for example, malaria and other health conditions are also on the increase. And we can also see increasing allergens. So these are some of the, these capture in this very visual form some of the impact of climate change on health. Now, if you had to zero in on sub-Saharan Africa, evidence from the World Bank shows that of the 60 countries identified as most vulnerable to the health impact of climate change, 38 are in sub-Saharan Africa. That represents 63%. And countries like Burundi, Eritrea, Ethiopia, Somalia, Niger, Gabon, and Madagascar are at particularly high risk. So in view of all of these are some of the justifications. The fact that sub-Saharan Africa shoulders the greatest health burden of climate change in terms of the most at risk of negative health outcomes, and also the fact that new diseases are assuming epidemic proportions in regions where they were previously not present. There is evidence of that happening currently in Kenya, where it has been found that 90% of issues of currently the evidence in Kenya reported shows that there has been cases of malaria happening, and these were previously not evident over there. So heavy rainfalls are usually antecedent to malaria epidemics, and it's pertinent that warming in the highlands of East Africa is enabling malaria-carrying mosquitoes to survive at higher altitudes. And this was something that was not formerly present. So it is showing that new diseases are assuming epidemic proportions in these regions. And there's also the projection by the World Bank that sub-Saharan Africa by 2050 will have the greatest share of global climate migrations, with estimates of up to approximately 86 million climate migrants in sub-Saharan Africa. Now, this adds to pre-existing burdens. We know very well that the burden of HIV is very huge in Africa. I think sub-Saharan Africa shoulders approximately 70% of the global HIV burden. This is already straining the public health system and making it very fragile. Now, we are also most vulnerable to having an additional burden of climate migrants. So this will put the health system, the public health system in sub-Saharan Africa at a very disadvantaged position in a very strained way, making it even more fragile. So these are some of the justifications as to why we have to think and engage in public health system resilience. Let's go to the next slide. Now, what can policymakers do? So here, there were emphasis on three main things that policymakers can do. Resource investment. Now, in talking about resource investment, one thing which is not stated on this slide, but is worth highlighting is a declaration, a political declaration called the Abuja. Abuja is the capital of Nigeria. So African government in 2001 met over there, and they came up with a pledge that they would dedicate at least 15% of budget to health financing. Now, from that time in 2001 to date, many African governments have failed to live up to that particular pledge. So here, the argument that I was making is that government must commit to increasing allocations for providing hospital facilities, tools, equipment, and increase in healthcare personnel. At least COVID has shown us that we need these things. There was a statistic that I saw that approximately 2,000 ventilators were in 41 African countries. Now, that is a very small number. And in South Africa, for example, the nurse ratio patient is 1:218. So this must change. And in that regard, the role of pressure groups cannot be overemphasized. It's very important that pressure groups put pressure on government to adhere to this very Abuja declaration that they committed themselves to. Now, following on from that resource investment direction, there is also the need for targeted policies. Now, climate change doesn't affect everybody equally. Different populations are at different risk of experiencing different health or public health challenges. About a couple of years ago, Zimbabwe had an issue of, I think, drought-occasioned famine, and women were at most risk of getting HIV because they needed to engage in transactional sex to be able to get food. So the public health system should, policymakers must engage in targeted policies to say, how do we help these vulnerable populations by providing HIV/AIDS testing and services for women and people who are living with HIV/AIDS? When there is a flooding, when there is an earthquake, how do we still continue to provide services for people who are, for example, living with HIV/AIDS? And the last point is the development of knowledge management platforms for information, skill, and technology sharing. Now, the role of science and multi-sectoral engagement. Over here, the goal is to get policymakers, for example, governments, ministries of education, to boost research. Resilience cannot take place in vacuum. There is a need for contextually valid, evidence-based research such that the interventions that we roll out do reflect the cultural sensibilities of the targeted population that we want to serve. So overall, these are some of the actions, the policy actions that policymakers, the African Center for Disease Control, and governments across sub-Saharan Africa should give priority consideration to in efforts to build system resilience for public health in relation to climate change matters. Thank you.
Thank you so much, Baffour, for sharing your excellent work with us. Up next, we have Shelbie Fishman. Shelbie is passionate about expanding access to the entire scope of healthcare that any one individual may need, primarily to those who are currently being stripped of those rights by our existing healthcare policies and infrastructures. This includes, but is not limited to, trans health and abortion care. Shelbie, I'm going to pass it over to you.
Thank you so much, Sarah, for that wonderful introduction. So hello, everyone. As Sarah mentioned, my name is Shelbie Fishman. I'm a current second-year medical student at Washington University, as well as a recent inductee of the Graduate Policy Scholars Program. So today, I would like to discuss how to talk about a topic that is often quite difficult to talk about, particularly in the state of Missouri, abortion. For my policy product, I produced a podcast, so I'll sort of just be speaking freely about some of the research that I did in order to cover this topic. So unfortunately, talking about abortion in America today, as we are all probably far too aware, does not actually lead to much talking at all. It often leads to screaming, to grimacing, to dismissing, to huffing and puffing, and ultimately to silence. As writer for The Atlantic, Caitlin Flanagan once expressed in her 2019 piece, "The dishonesty of the abortion debate, why we need to face the best argument from the other side." And in a follow-up podcast interview on the submission, she said, "One of the many reasons that the abortion argument is pitched in screams is because both sides know if they calm down and listen, they would have to admit the best argument of the other side is a pretty good argument." Now, as a staunch believer in every person's right to an abortion, this approach is not always one that I am so keen on taking, especially while living through the reversal of Roe v. Wade and the subsequent ban on abortion that was implemented in Missouri last summer. That being said, I think Caitlin Flanagan's point, which mirrors a number of other journalists and political writers today, as abortion has become one of the most polarizing issues in our country, is a curious one. So let's say that she's right, that what we really need to move forward is to talk to one another, and more importantly, to listen. My question then became, how exactly do we do that? And according to a report released by the Pew Research Center in May of last year, which will be the focus of our conversation today, entitled "America's Abortion Quandary," they found that a majority of Americans say abortion should be legal in all or most cases. but many are open to restrictions. Many opponents of legal abortion say it should be legal in some circumstances. So there are many nuances to this conversation, and this report really looked at the hard numbers of where those nuances lie in our current population. So let's dive in. In order to generate this report, the Pew Research Center surveyed 10,441 U.S. adults from March 7th through 13th of 2022. Each participant is a member of the center's American Trends Panel, which is an online survey that is recruited through national random sampling of residential addresses. So nearly all U.S. adults stood a chance of getting selected. The survey is also weighted to be representative of the U.S. adult population by gender, race, ethnicity, partisan affiliation, education, and other categories. The report also specifically mentions in its introduction that this investigation aimed to measure views on abortion in the context of the many nuances of the debate and individuals' opinions by using a wide array of questions in many different ways to represent multiple possible factors and influences, such as the stage of the pregnancy, the circumstances of the pregnant person, the health of the fetus, and many other possible complications or scenarios. In sum, the report generated 3 sections: Americans' views on whether and in what circumstances abortion should be legal, social and moral considerations on abortion, and how the issue of abortion touches Americans personally. We'll be focusing on findings from the latter 2 sections for the remainder of this talk. So in terms of the social and moral considerations on abortion, the survey revealed that very few Americans view the morality of abortion in stark terms. Just 7% of all U.S. adults say abortion is morally acceptable in all cases, even though 61% say that abortion should be legal in all or most cases. And 13% say it is morally wrong in all cases, while 37% say it should be illegal in all or most cases. So one's moral opinion does not always align with their political views. And then a third say that abortion is morally wrong in most cases, while about a quarter say it is morally acceptable most of the time. An additional 1 in 5 do not consider abortion a moral issue at all. The review finds that there is strong concordance between some people's views of whether abortion is morally wrong and whether it should be legal. Among U.S. adults who take the view that abortion should be illegal in all cases without exception, 86% also say abortion is always morally wrong. The predominant opinion among adults who say abortion should be legal in all circumstances is that abortion is not a moral issue. But some portions of this group also say it is morally acceptable in all or most cases. Similar trends follow for Americans who say abortion should be illegal or legal with some exceptions. When those who said abortion is morally wrong, in at least some cases, were asked whether there are situations where abortion should still be legal despite being morally wrong, roughly half say that there are situations where abortion is morally wrong but should still be legal. Only 22% say that whenever abortion is morally wrong, it should also be illegal. Interestingly, the survey found that across both political parties and all major Christian subgroups, including Republicans and white evangelicals, there are substantially more people who say there are situations where abortion should still be legal despite being morally wrong than there are who say that abortion should be illegal when it is morally wrong. With respect to the subject matter of this particular discussion, there is a subsection of the report that asks, how do certain arguments about abortion resonate with Americans? Here, the survey presented respondents with 6 statements and asked them to rate how well each statement reflects their views on a 5-point scale. These statements included 3 phrases, often cited by individuals wishing to protect a right to abortion, and 3 statements that align with arguments sometimes made by those who wish to restrict access to abortion. Among all of the statements presented, the greatest proportion of Americans are most likely to say that women alone should decide whether to have an abortion, and that making abortion illegal will lead women into unsafe situations. So that's 53% of Americans. On the other hand, about 40% support the idea that human life begins at conception. So a fetus is a person with rights, and a third say that if legal abortions are too easy to get, then people won't be as careful with sex and contraception. Finally, and in my opinion, most importantly, the authors of the report analyzed certain statements together to allow for, quote, examination of the extent to which individuals can simultaneously hold 2 views that may seem to some as in conflict, unquote. For example, 1 in 3 U.S. adults say that both the statement, the decision about whether to have an abortion should belong solely to the pregnant woman, and the statement, human life begins at conception, so the fetus is a person with rights, reflects their own views, at least somewhat well. Again, that's 1 in 3 Americans. This includes 12% of adults who say both statements reflect their views extremely or very well. Of note, Republicans are somewhat less likely than Democrats to say both of those statements reflect their own views, at least somewhat well, according to the report. Finally, I would like to read the following excerpt from the report from a subsection entitled, Their Words, How Americans Feel About Abortion. When asked to describe whether they had any additional views or feelings about abortion, adults shared a range of strong or complex views about the topic. In many cases, Americans reiterated their strong support or opposition to abortion in the US. Others reflected on how difficult or nuanced the issue was, offering emotional responses or personal experiences to one of 2 open-ended questions asked on the survey. About a third of respondents opted in. One open-ended question asked respondents if they wanted to share any other views or feelings about abortion overall. By far, the most common sentiment expressed was that the decision to have an abortion should be solely a personal decision, or a decision made jointly with a woman and her healthcare provider, with some simply stating that it should be between a woman and her doctor. Others made a more general point, such as one woman who said, a woman's body and health should not be subject to legislation. And that is the majority of what I discussed during my podcast that I submitted for my policy presentation. I just saw that someone mentioned slides. I didn't have any visuals for the slide, which I apologize for, but I can definitely repeat any of the statistics that I presented during the Q&A portion. But just to respect everyone else's time, I'll let Sarah continue on with the program.
Thanks so much, Shelby. Next up, we have Melody Frempong. Melody is originally from Ghana. She holds a Bachelor of Arts in Social Work and Sociology from the University of Ghana. Her research areas include mental health, substance misuse, gender issues, and asset development. Her passion for social work motivates her to be concerned about factors affecting people's lives, including mental health. She is also interested in the nexus between social work and policy and how policy could be used to shape human lives. She recently graduated with an MSW degree, Master's of Social Work, that is from the Brown School, specializing in mental health. Melody, please take it away.
Thank you so much. And hi, everyone. Just like Sarah said, I'm Melody, and then I'm from Ghana. So today I want to talk about maternal healthcare policy in Ghana. And to start with, we may all know that maternal mortality is something that the whole world is dealing with, and especially in sub-Saharan Africa. Recent data from CDC and also the World Health Organization shows that sub-Saharan Africa accounted for the highest mortality rates in Africa, of which Ghana is not an exception, such that there is 546 deaths out of 1,000 lives per death as of 2015. When we talk about maternal mortality, we can simply define it as death of a mother or a woman during pregnancy, at delivery, or right after childbirth. And so why should we care about maternal mortality? First of all, I think that most maternal deaths are preventable. There are a lot of research out there which shows that there are a lot of deaths that could easily be preventable. There are also solutions to manage these complications that we all know. Secondly, when you come to internationally, maternal mortality, it's also used as a measurement or an international indicator of the health of the population of a country as well. And lastly, I think that maternal mortality is a tragedy to family, parent, and even the child itself, or let's say the whole country itself. So to respond to this, in 2003, the government of Ghana introduced the maternal healthcare policy, the National Health Insurance, of which the free maternal healthcare policy was part. And this policy was, first of all, currently Ghana has 16 regions. It used to be 10, but as at the time that this policy was implemented, it was only done in 4 main regions, which were categorized as the most deprived areas, right? And so as part of this policy, mostly what it does is that it kind of prevents help women to receive healthcare during pregnancy and childbirth. This includes vaginal birth or any other things that may be necessary. That is what is written in the policy. But today, and as at the time that the policy was implemented, we see that it is undeniable that, of course, there has been tremendous progress. When you check the data or in the graph that I've presented here, you can see that over the years, there has been a decline, but then this decline has been very steady, or this decline has been very slightly, which when you compare it to the sustainable development goals, you still see that Ghana is still lagging behind when it comes to preventing maternal mortality. And so just a quick shot from the data in there, you can see that as of 2015, there were still mothers who were dying in childbirth. And as of 2020, which I could say like the latest statistics that we have, at least the country experienced more than 200 deaths, which shouldn't be so. Now, what are the causes? Why is it that we still have this policy in practice, if I should say, but then mothers are still dying when they go and give birth to their children? So first of all, when you compare the statistics of the number of women who die during childbirth or right after delivery, you could see that the number is higher in rural areas compared to like in the urban areas. Although both areas experiences, the disparity lies hugely in the rural areas. And so one major thing, apart from the biological or the medical factors that could cause a mother or a woman to lose their life during childbirth, one of the other factors which could be preventable or which could be rectified with policies, one of the causes that the availability of skilled personnel and then skilled personnel attendance in the rural areas is way lower compared to the urban areas. And when you check the statistics that I have, you can see that in urban areas, we have 74% for personnel, health personnel who could attend to mothers or women during childbirth. Whereas in rural areas, we have like very little, which is like, subjectively little, which is like 43%. The reason for this, it could be explained in a lot of reasons. One, most health personnel will prefer to be in the urban areas because they think that, well, these areas are so deprived, and so they wouldn't want to go to these areas too. Secondly, the other thing too, that although most health personnel will be willing to go to these areas, the logistics or the necessary tools or whatever equipment that they need to render their services are not available. And the other thing too is also transportation services. Though health personnel may be willing to go to these rural areas to practice or to render services to women or healthcare in the whole, transportation is also a challenge. The other thing, like I already mentioned, which is also interrelated to the first one that I mentioned, is lack of limited logistics. So what happened in Ghana was that, or what is still currently happening, is that ever since this policy was implemented, only a few healthcare institutions has been extended. So for example, before the policy, if we had just one hospital that was serving a municipality, we still have one hospital serving this whole municipality, despite the increase or the continuous increase in Ghana's population, which typically shows that it has not been enough. If we have the policy and then we are still using the same services that we had, then there's no way that this policy is going to make the expectation that we have. The other thing too, it's also social cultural factors. And most Ghanaians, especially those in the rural areas, still believe in traditional medicine, which I wouldn't say it's not good. Definitely it is good. People still have beliefs or myths about childbirth, receiving care in the home rather than going to the hospital, of which all these beliefs needs to be demystified or needs to be explained to, especially most women who are not educated. And the other thing too is that although this policy has been implemented, there is low antenatal care. So for example, although you may be enrolled in the insurance, you may go to the hospital and then they will tell you that your insurance doesn't cover this, it doesn't cover that. And so although we have the policy process or in practice, is literally covering very little. But then the majority of the services that are needed during childbirth or delivery are not covered. And the other thing is that there's also still existence of out-of-pocket payments. And most women sometimes, although they may be enrolled in the policy, they'll be told the hospital facilities can tell them that, hey, your X-ray is not covered, your MRI is not covered, and a whole lot of things. So most mothers feel that, well, there's no point to even go to the hospital in the first place if I have to pay for this or pay for that, despite the policy, despite that we have this policy in practice. Now, also in 2017, the Ghana Maternal Health Survey also reviewed that almost 14% of all deaths, 10% of them were direct maternal causes and 4% were indirect, of which the indirect entails like a lot of factors and all of that, yeah. And also it suggests that 2/3 of death were direct maternal death, which still means that maternal mortality is still on ascendancy in Ghana. So just to wrap it up, what do we think we can do as a country, or what do we think we can do as a nation? So first of all, this is not, even for this policy, there are a lot of policies, or there are a lot of services that has been implemented that they also still feels the problem. The first thing that could be done is to strengthen the public health system. It is totally impossible to achieve the sustainable development goals if our healthcare system are not strengthened. And so, first of all, we are calling on policymakers, or I'm calling on policymakers to address these gaps that are already existing in the public health system. And so if you want a policy, or you want mothers to enjoy the best of their health, it's important that you kind of recognize the gaps that exist in the healthcare systems. The other thing too is about transportation. So most of the women in the rural areas, specifically, even those in urban areas, have transportation challenges. And so there may be hospital around, but then they would have to travel different miles just to get to a hospital. And so in order to prevent that, they would rather resort to traditional means or personal means for childbirth or whatsoever. The other thing too is that it is important that policymakers encourage introducing maternal health education in the policy, because most mothers actually do not know what happens to their body during pregnancy. Most do not know what even postpartum, what depression is, or what peripartum depression is. So it is important that we include all these things into the policy in order to ensure that every mother or every woman goes to delivery or experience childbirth in the smoothest and safely way. Thank you.
Thank you so much, Melody, for sharing your research and policy recommendations with us. Last up, we have Noriko Hatanaka. Noriko's primary interest is international disability rights. Noriko would like to support the International Society through better policies obtained by analyzing the roles of vulnerable people and reflecting their voices on a global scale. Noriko, please take it away.
Thank you so much, Sarah, for my introduction. Hello, everyone. I'm Noriko Hatanaka, a current Master of Social Policy student at the Brown School. I'm originally from Japan. In fact, I completed an MSW program at the Brown School and United Nations internship program on disability program last summer. But to become an equity-focused policymaker, I returned to the Brown School in January. My primary focus is international disability rights. I know American disability rights activism is very influential across the world, and I've researched many disability rights efforts in the United States context for the spring semester. Today, as a disability rights activist, I'd like to discuss the Disability Integration Act, DIA, and its status. Since before the COVID-19 pandemic, the need for long-term services and supports, LTSS, which are crucial for independent living, has been a long-standing concern for the disability community. Although the Americans with Disability Act of 1990 prohibits discrimination against individuals with disabilities and requires reasonable accommodations, many state institutions have been slow to provide the necessary infrastructure for the institutionalization, resulting in the illegal segregation of individuals in need of LTSS by limiting home and community-based options. The Disability Integration Act is a bipartisan effort and aims to address these issues by granting people requiring LTSS the right to live in their own homes rather than in institutions. It offers a practical solution, eliminating unjust practices that force individuals into expensive institutions solely due to their need for assistance. The DIA also mandates that Medicaid and private insurance provide equal opportunities for LTSS in a person's home, mirroring institutional care. This legislation would remove the institutional bias that forces families to choose between institutionalization and shouldering the financial burden of out-of-pocket expenses. The U.S. Census Bureau projects a significant increase in the aging population, with over 84 million Americans over the age of 65 by 2050, leading to higher instances of poorer health and disability within households. As private insurance policies rarely cover long-term care costs, families are increasingly burdened with catastrophic expenses. In cases of financial limitations, family caregivers often bear primary responsibility for the care of their parents or spouses. Medicare does not cover long-term care expenses, categorizing them as assistance rather than health care. Research unequivocally demonstrates that institutionalized care for LTSS is less cost-effective compared to living in the community. Individuals with disabilities who reside in their own homes or with family experience a higher quality of life and community engagement. Projections indicate a significant strain on families and Medicaid due to rising demands for LTSS, necessitating a fair and practical solution. Implementing a national program like the DIA that offers better and more affordable long-term services at home is the optimal solution, benefiting all Americans. I wholeheartedly support the call for Congress to hold an immediate hearing on the DIA. I advocate the importance of activism in promoting a publicly funded healthcare policy that enables families to remain together in their homes and communities. Thank you so much. That's all.
Thank you so much, Noriko and Melody and Shelbie and Baffour. Thank you to all of our scholars and sharing your work with us today. I'm going to start it off with a question that I would love to hear from each of you on this. And while I do that, those of you who are in the audience, please feel free to pass along any comments or questions. But my question for all of you is, you know, in this world of health and mental health, disability rights, environmentalism, you know, all the things that you all are talking about, you know, you can do micro practice or you can do macro practice. Macro practice looking at, you know, policy stuff like you all are doing. And I'm just wondering what drew you all to the macro level policy work as opposed to maybe micro direct practice work. And I'd love to hear from each of you on this. What drew you to macro level work? Before, you want to go ahead and start?
Yes, I want to start. I think the first reason is because policy determines line of action. Policy determines who has access to something, because policy is intricately intertwined with law, and law shapes the course of things. Policies are bedrocked on law. So if maybe we have a legal provision that says that abortion is illegal, because you spoke about abortion, so let me just use that, then it means that women who may need that service to survive may be at a disadvantage. So in order to help address these issues, we need to engage with policymakers, because when they help change policies and laws and other macro level structures, we can expect a trickle-down effect. It's not automatic, but at least we can expect that there could be further engagement, and there could be mechanisms of actions, plans, strategies that would ensure that populations affected would experience relief in whatever way that the issue affects them. Yeah.
Thank you, Baffour. How about the rest of you, Noriko, Melody, Shelbie? Any other thoughts on why you all were attracted to the macro policy level work as opposed to micro direct practice?
So for me, I think that my topic I was attracted to because, first of all, women are the people who bring people into this world, right? We all came out of a woman, yeah. So and this is something that exists. It's not just in Ghana, it's in the whole world. Current statistics shows that we are still, when it comes to the global south or in most African countries, it is still prevalent. Even in the Western world, it's still prevalent. But then I think that it's important that we all come together at a macro level to solve it. It is not a one-person thing. It is not, like I said, the government can do their best. They can do all that we want to do. But then what happens if, let's say, health personnel are not also ready available to deliver what they expected to do? And so these are the things that attracted me, because first of all, we all care about children, we all care about women, and women makes the world, not to sound biased and all that, but we all know that, right? Yeah, so that was why I was attracted to that, and also calling for all of us to get involved to rectify this problem. Thank you.
I love it. Thank you, Melody. Shelbie, Noriko, do you guys have different perspectives or similar ones?
Yeah, definitely similar. I would say, particularly maybe with the topic of abortion, I feel as though, especially right now, the sort of micro interactions often are not always necessarily lining up with what we see in policy. And I feel like policy is what is generally regarded as this great reflection or mirror of where our society is in terms of how they feel about a given topic. And abortion seems to me to be one of those that is just so nuanced that it really can't be necessarily reduced in a macro policy context. And so that really drew me to kind of dive deeper into what are some of the, legislative actions that are happening right here in Missouri, and how does or doesn't that reflect some of the micro interactions and dynamics that we see here on the ground within our community. And so I think aligning those two things as best as possible can make policy that much more powerful in terms of driving outcomes that are, for the common good, as we all learned in government class when we were young.
Great. And Noriko, how about you?
As for me, I think I have a specific experience about this. In the first place, my aunt has severe cerebral palsy, and my grandma is an activist. Their activism continued for over 60 years. Since childhood, I advocate their activism. And I have a strong interest in how vulnerable people can fulfill their lives by obtaining financial resources and other resources. Also, I have 17 years professional experience as a banker because I have a strong interest in financial resources. Through my activism and professional experience, I realized that I need to pass social policy, social work practice, and how to design policies because our activism reach out to the discriminatory law and policies anytime, even in the context of my country, Japan. So luckily, last year, I completed super macro level internship at the United Nations. And then I noticed that international society eventually noticed that they are lacking disability rights factors in many aspects in this world. So this summer I plan to work on incorporating, for example, international disability rights, CRPD, into local government policies with my supervisors. So I will have exciting experience this summer. Thank you.
That sounds great. And you know, Noriko, hearing about your previous work in a completely different field, and then Baffour also kind of mentions, you know, in your answer to the previous question about integrating law, that made me think about just the different disciplines, different skill sets, different academic knowledge that good policy development and advocacy really needs. And I'm wondering if for each of you, if there was, you know, during your time so far as a in the Graduate Policy Scholars Program, if there have been any, you know, skill sets or you know, different learnings or information that you've had to acquire that surprised you, that you were like, oh, this is kind of outside of maybe what my academic training has been thus far. Like, how has it stretched you? What have you had to learn that maybe you weren't expecting to need that kind of a skill?
Can I go first?
Yeah, Melody, please.
Okay, so for me, one thing that I really remember is remember our training on writing op-eds or letter of editors too. Yeah. And in the Brown School, these are things that we do a lot. And so with that particular training, I was very impressed with the resource person that he brought, because coincidentally or fortunately, I had an op-ed due for one of the classes, and I think it was a very timely one that really helped me when it comes to writing an op-ed, how to pitch your idea, like how to even put your idea, what you want to put across, how you want to make your opinion catch the attention of your readers, right? Yeah. And I think that is something very important that not even only people who are in grad school are supposed to do, but then everyone, as far as we are concerned about policy, as far as we want to make changes, because that is the best way that we could get our voices out there. Yeah. So that's one thing I remember. And I'm grateful for. Thanks.
Thanks, Melody. Yeah. How about the rest of you? Is there any skill or piece of information in particular that surprised you or that you felt was really impactful for your ability to, you know, be an emerging policy leader?
I can go. I remember it was one of the trainings, I think Dan Ferris, who I believe is on the call today, presented about analyzing different policy pieces. And we, through the course of the training and subsequent discussion, kind of talked about how analyzing policy can be like, doesn't just occur at the end point of when a policy product has actually been produced. It can sort of be implemented at different stages when you yourself are the policy maker and you're analyzing policy that you're creating versus analyzing policy that someone else has put out. And I just felt like the tools that he presented there were very flexible, and it wasn't exactly it sort of changed the way that I think about analyzing policy and at which point policy analysis can really come into play and just how adaptable those tools can really be. So I found that to be very useful.
Sure. So policy is more of a living, breathing, changing document rather than kind of a hard copy only implemented at the end. Very cool. Noriko or Baffour, anything that, any reflections for your time thus far? Things that you've learned that have been particularly impactful,
in the Brown School,
or outside of the Brown School, but something that you feel has really impacted your ability to become an emerging policy leader.
well, about the fact that I have done some classes in policy. I've taken some classes in policy, and I've also taken some classes in classes in policy, classes in social engagement and community participatory roles. And these are some experiences that I've had that have really shaped the way I think about matters of policy. And my experiences over there in the Brown School, learning about matters of social engagement and community participation. I think that has also been very important, learning about how to help communities, low-income communities, to develop mental health structures and public mental health issues. So these are some of the experiences. And the fact that I was also involved in global health matters on campus. I was the chair of WashU Global Health Student Advisory Committee. So this has helped me a lot in shaping and making me have a broad understanding of the volume of global health work, research, and community engagement done within Washington University in St. Louis.
Awesome, that practical experience. Yeah, great. Noriko, if you want to close us out, anything that you felt was particularly impactful in learning how to, develop and implement policy.
Okay. My interest in international disability rights are very interdisciplinary, as everyone knows. So I understand I need to learn about a variety of areas. So initially, I intended to limit my ideas in the field of disability rights themselves. But this summer, I try to work on child protection or more gender-based practices. So yeah, I think to expand the skill sets as policymakers, they need to learn about a variety of areas. That's all.
Thank you so much. Well, we are just about out of time, so I just want to end by sharing my congratulations, as well as in the chat, we have a few congratulations as well to the four of you who were willing to share your research, your policy with us today. As well as all of this year's inductees into the Graduate Policy Scholar Program. And I'll just share what somebody in the chat, because it's such a nice quote, they said, the presence of such excellent international scholarship honors the axiom that all health is global all of the time. So excellent work to all of you. And thank you again for sharing with us today. And thank you all for being here. Today's session was recorded and it will be shared along with all of our other past open classroom programs on our website. I'm dropping a link to that in the chat so that you can go back and watch this. We have 2 more open classroom programs left this season, and then we'll take a short summer break. I hope you all will consider joining us for those, and there's a link to that in the chat as well. But it's 1:30, so I will say good day to everyone. Thanks for being here, and goodbye, everyone.